Without further ado, I'd like to introduce Dr. Jason Highsmith. Dr. Highsmith comes to us from Tampa, Florida. He's a dual licensed physical therapist and a PhD in medical science. He's Deputy Chief of Research and Surveillance for the VA and DoD Extremity Trauma and Amputation Center of Excellence. He is joint appointed as an associate professor at the University of South Florida's School of Physical Therapy and is immediate past president of the American Academy of Orthotics and Prosthetics. Jason?
It's a privilege to be here, and as was just mentioned, I just want to start by saying that this international perspective, obviously I don't fully understand the Canadian reimbursement model. I barely understand the American reimbursement model. I'd also like to say that the American reimbursement model has changed for a lot of reasons at breakneck speed here very recently. And we're all adapting to that. And when I started getting involved first in clinical practice and had those starry-eyed, maybe I'm going to say naive views about helping the world one patient at a time, and then that started changing very quickly when you started having to list all your codes down and account for your time and all that. I never would have imagined that I would have gotten into it, into this field to take on payers, basically. But a lot of what we do sometimes now is dealing with that. So what I'm going to share with you is the impact of basically research and education on clinical practice, and I'll caveat that from the United States of America's perspective a bit. So these are my appointments. I have no disclosures, and so here we go. Bear with some small font here. I'll make it as painless as possible. So essentially, I want to present to you that evidence, basically research evidence, does have a considerable impact on practice, and more so in America these days by having a significant influence on reimbursement. Again, these are my opinions. So just to kind of set the stage a little bit, this question commonly comes up, when does the clinician become concerned with research, or why would the clinician become involved with research? And here are just some questions to ponder with that. Maybe the clinician has identified a clear knowledge gap. Maybe they have a clinical question that they would like to have answered. I know a number of people that have pursued a PhD for specifically that reason. And then years later have been able to answer that question. Maybe there's a trend in practice that they're recognizing. Maybe there's a compelling RFP that could do some good in their area. Maybe they have noticed, as has been the case recently in the States, that reimbursement is getting, quote, worse, or maybe they're actually finishing that graduate degree. One thing that's been said to me is that, well, as a researcher, pointy-headed academic and other things that we've been called, you just simply live on a different planet. And I would point out that we all live on different planets if you want to view it in that way. Here are just a few within the galaxy of different planets from which we all live. And so you just have to think about the perspective. And maybe it is perspective. So here are some of my favorite examples. We all talk about the perspective of the glass being half full or empty. That's a perspective. Here's a nice one about a man stranded on an island. Sees a boat coming up, hey, boat, and the guy on the island sees it quite the other way, My favorite one is, I was walking out of church one day and there was a mud hole. We're all dressed up in our Sunday best. And my then 6-year-old looks down at the mud hole and he starts to take off, and I grabbed him by the shoulder and I said, as much fun as that would be to dive in that, let's go home, I'll change you. And then I'll make a mud hole in the backyard and you can dive in it all you want or whatever, because the perspective was quite different. And the point of that is that, when we start looking at from the research perspective, from the clinical perspective, from the patient's perspective, from the payer's perspective, the policymaker's perspective, we all have a different vantage point from which we're looking. And it's important and it matters. So again, back to the question, when does a clinician become concerned with research? What about this evidence-based practice thing? Here's another thing to consider is that, the world has its natural axis, but then there's also this axis of money, right? And then there's the clinical axis. I want to do this for my patient. I want to do this good with them and provide these components, but they all actually make things, again, look a bit differently. So now, I've got a few painful slides like this. I'll just kind of read you the punchline of these, but let me just give you some context for what this is. These are documents from basically payers or policymakers that essentially tell us what we will and what we won't do, or what the evidence will or won't support in the states. And so in a lot of ways, you're starting to see the payers actually have control about what patients get and receive. And it's unfortunate in many cases. But I hope in the background you're thinking that, well, then we need to prove things. We need to prove that things work or don't work. We need to find out what's best, because we want that language in these documents. Because right now, other people are writing these that maybe don't have a full understanding of what patients really actually need. So I'm just going to share with you a few slides of actually what is in some of these documents and how they affect us. So essentially, this first one is from CMS, which is basically our Medicare system. And so pause, break there for one more second. We talk about sort of socialized healthcare reimbursement, socialized healthcare provision. Two systems in the U.S. are about as close to that as we get. The CMS is one of those, and the VA DoD systems are another. And I'll present to you in the second talk I'm a part of later from more the DoD and VA perspective. This is more from the larger CMS and private payer perspective. So in this case, basically this is suggesting that a number of claims, in this case it says in 2010 Medicare allowed nearly 1,000 claims inappropriately, and it goes on to describe some of the tenets of those inappropriate claims. Here's some interesting language. Miscoded orthotics resulted in $33 million in excessive Medicare payments. Here's another one, $43 million in lower limb prosthetic payments that were inappropriate. In recent years, there was also a VA, that's our veteran system, Office of the Inspector General report that said basically it was less about attacking fraudulent claims or listing those, and more about describing the veteran population and what the needs were. So that was actually a more positive and favorable perspective to get that feedback from a policymaker. But the bottom line was this. What we realized very quickly is that when the money stops, innovation stops, and the desire to provide higher quality services and more innovative solutions for patients also is stifled or stops. And that's the bottom line. And so if that isn't starting to show you that there's a need to get evidence out there about the things that we do, I don't know what else it will take to convince you of that. So let me give you a few more examples from the commercial world. These are our for-profit payers. And what I always tell my students, if you think that insurance companies are there to pay for services that people need, you need to think that maybe they're there to actually help shareholders make a profit. Okay, and there's a considerable difference between those two things. So here's a few. Here's one from Cigna regarding elevated vacuum suspension sockets. And it says basically there in red, peer-reviewed scientific literature is insufficient. It goes on to say generalization of results about the studies that are published, which are few, by the way, to larger populations cannot be made. Regarding microprocessor ankles, here's one that says outcomes are encouraging, but there's insufficient evidence to support clinical utility. Here's one that's kind of positive from Cigna. It actually acknowledges the work of the American Academy of O&P putting together a clinical standards committee and actually defining stages of care. So this is the reimbursers acknowledging some of the work that the professional organizations do. So those of you that are volunteering for the local professional association, it is acknowledged, it is recognized, it does have value, and I think that's important. Here's another one about microprocessor knees, and it basically says that the evidence continues to evolve, but there is evidence supporting effective use of these devices in a certain limited group of patients. Here's more evidence that microprocessor knees have some recognized value. Here's one that's very disturbing from a group called Aetna, which is a commercial carrier, and it says that Aetna considers lower limb prostheses experimental and investigational because of insufficient evidence in the peer-reviewed literature, with the exception of some caveats, and it lists those I mean, imagine that you're paying for Aetna insurance coverage and this happens, right? I mean, this is a problem. And then there are some that maybe aren't completely clear in one direction or the other. This is one from the Washington State Healthcare Authority. And it says here, existing literature has demonstrated that microprocessor knees are likely associated with basically favorable outcomes in a certain group of people. And it goes on to say that sort of ecologic validity or real-world settings is questionable. I can't disagree with that, frankly. I mean, there was some ecologically valid work done in that area, but it could be improved for sure. So now, there's some of the doom and gloom stuff. Let me show you a few more things, and then I'll show you some things that we know, and I'll try to start bringing that to a close. I don't want to occupy the whole time. We've got a robust panel that we want to hear from. So here are some examples of symbiosis between research and practice. So today, at least where I'm at, more microprocessor knees are fit. We fit a lot of veterans with microprocessor knees, and I think that, in my opinion, a lot of those folks are probably suffering less falls and experiencing some functional benefit and these things. And there's evidence to prove that, and it's consistent. With regard to VAS, more VAS, at least in my area, is being fit. I think there are a large number of clinicians that have an interest in that. That probably helps drive it. We also have a large number of research grants in that area, so it elevates the interest where I practice. And so there's that reality, but then there's also the reality that I just showed you that the commercial carriers, and even CMS to some degree, says that the evidence is not there to support it and to reimburse it. So we're working on it. We're pushing that innovation envelope, but the payers aren't exactly in line with us and with our thinking yet. We still have to drive. If we think that's the best thing for our patient, it's on our shoulders to prove it. And so that's what we're trying to do. With regard to microprocessor ankles, same thing. The language was there. The literature is evolving. The practice probably will as well. I can tell you in our center, we fit 18 biome ankles over the last 2 years. I know this because we're doing a retrospective analysis on it, and there's an alarming rate of rejection. But the few people, about 25% or so, that have kept it, swear by it, and can point to 4 or 5 different reasons why they need it. And, you know, again, this isn't a biome ankle talk or anything, but again, practice is evolving. The literature is not there, and so it's up to us to prove it. So I'd say here, which is first? And the way it usually works in the prosthetic orthotic community is that the technology comes out first, and then we have to figure out how to integrate it or if it has a place in our practice. Wouldn't it be nice if we could get to a place where we live like the pharmacists do, and we have a piece of evidence that says it will do A, B, or C before we get our hands on it and try to put it on a patient? But we're not in that world, okay? So chicken and egg, which comes first? So I would suggest that research clearly impacts practice, or at least in my neck of the woods, at least reimbursement, and that affects practice. But the problems we face, in my opinion, is that the O&P community, like a larger sector of the rehab science community, lacks enough research, lacks enough researchers. We lack research funding. We lack training opportunities for researchers, and we lack adequate clinical partnerships. I had a 2-sentence conversation with Dr. Hafner right there this morning about his colleagues are canvassing the entire East Coast. Okay, they're from the Pacific Northwest. I'm from the southeast of the U.S., so he's over in my neck of the woods canvassing the entire East Coast. Because why? We lack adequate clinical partnerships to power our studies. I will tell you, grant sponsor groups that I speak with, their members tell me over and over, they're tired of seeing the 20-subject study. They're tired of seeing it. And the only way that's going to happen is if we start building these networks and these partnerships, even across international borders, Dr. Rashke. She reaches out to us all the time to do things, and so we're so thankful for that. So here's another thing about how do we know. Recently, we've looked at, in some of our systematic review work, actually counting funding. And so here's the results of our first sort of look at that. We just published a systematic review, and in the body of work, which only included high-quality, rigorous clinical trials and systematic reviews, 26% of the high-quality studies included in that review were unfunded, a quarter of them, okay? And that's actually not too terrible, okay? But 26% were unfunded. So the other thing to know with that is that when you look at a very crude rate, and there's no great formula for this, we just kind of made it up, I'll just be honest with you, is that we're putting out evidence statements at a rate of about 1 statement per year when you look at the rate from high-quality evidence. We have to be, I think, producing evidence faster than that, and I mean high-quality evidence faster than that. The only way that's going to happen is if we increase our research funding, increase those training opportunities, get more scientists in the field, that kind of, and actually partner with our clinicians. I mean, we have to be doing this together. It can't just be in the research labs. It's got to be in the clinics is where it's got to be. So the other thing, and this one always annoys people in the U.S., but it's a fact, in that particular review, there was no funding from the NIH in the review of 16 years worth of literature that we looked at. And those were all clinical, patient-oriented studies. And the people that have some of that funding, you can slam your hand on the desk all you want, but the studies are there and you can look at them for yourself. So what do we do? And what are some of the other problems? Well, we look to outcome measures. Well, if we're going to start proving things, we can document with outcome measures, right? Problem is the research community does not agree on any particular single outcome measure or battery of them, nor does the clinical policy or reimbursement communities for that matter, so we're all speaking different languages. We want objective evidence of outcomes, but we don't know exactly what we want to measure or what we think will give us the biggest bang for the buck. The problem is I've been working a lot with some economists in my area recently, learned a lot, done some analyses, and basically if you don't agree on common outcome measures, you're not going to get to economic analyses with any consistency. And so just to see what we had, our group went ahead and looked at reviewing economic literature. And fortunately, we were able to actually conduct a review. It was a very small one, albeit, but we did get to it. And the review included basically cost consequence or cost description level studies. And in the economic community, those are the lowest forms of evidence in the economic world. And so we have a long way as a profession to go when it comes to economic analysis. So if we're going to prove value, we're going to have to start looking there for sure. And so, again, you just have to remember we have a lot of work to do there, and that is describing value. So this is the what do we do. We had a recent strategic planning meeting with the Academy of O&P, the American Academy of O&P, over the summer. We did one last year, and we kind of brainstormed basically this list. And we're trying to chip at things from this list. So what can we do? What should we do? What will we do? Well, we need to actually conduct better quality research. We need to conduct economic analysis. We need to get these training opportunities. And the Academy does a lot with secondary knowledge and knowledge translation efforts. We need to do more of that. We need to get everybody speaking the same language, basically. We do need to push toward adopting outcome measures, which means training in schools to do it, training for clinicians to do that. We need to be able to define our target population. What do I mean by that? When you look at the best epidemiologic studies that we all cite, at least in America, you'll have your own for your respective country, we talk about there's 1.6 million amputees or 1.8 million. The reality is those are done from estimates from like 2 states or something in the U.S. The fact is we really don't know how many of these people that there are. And I know that since I've become the Deputy Chief of Research and Surveillance for the VA, we have a very meticulous count of our veterans. We have about 85,000 veterans, plus or minus the mortality that happens in the system. We need to be able to say that for our populations, and we can't do that. Right now we use epidemiologic estimates, the best we have, and we're thankful for them, but we need to have better definitions of that. We need to grow our professional presence in our nation's capital. In our case, probably need to do the same for yours. And then we need to work toward drafting better local coverage determinations or national coverage determinations or whatever that language is going to ultimately be that I showed you earlier that currently exists. It needs to be replaced with something that makes more sense. And the only way it's going to make more sense is if we have more evidence to feed into it, which means we're doing a better job collaborating between academia, science, and clinical practice. So I put this continuum up and ask you to think about different interventions that you provide, maybe even your practice as a whole, and ask you to think about where are we. Some people, well, the poll this morning you showed was fantastic. Looked like there's a lot of uncertainty with evidence-based practice, for instance. So here's just an example. Where are we on this continuum? Take any particular area of practice. For instance, microprocessor knees is a favorite one because there's a fair amount of literature that's emerging. Yes, it has some things that it could develop on for sure. But I would say that if you look at this continuum and apply just that intervention, just microprocessor knees, for instance, I think we can say there's some rigorous research there. I think we can say that there's a demonstrated record of success for improving outcomes in patients generally, certain types anyway. And then there's been some systematic review there. Okay, so I would say that's an area that according to this continuum we could say has some evidence-based practice. But I would also encourage you to look at the other end of the spectrum and ask how many interventions do we provide that are in the unestablished practice area that are based on no research, that have no data supporting efficacy, and are just solely based on judgment. And there's nothing wrong with that, except to say that we can do better. That's what I'm saying there. So within all the interventions we provide, we vacillate on these continuum. And so the other question that comes up sometimes is clinicians, again, will look at academics and say, well, you know, if we have to wait on you to publish a study and get a grant and all these things, it'll take forever and we won't be able to prove what we're doing, so we're going to have to just rock along. The truth is, evidence-based practice is a three-legged stool as it's commonly described, and it includes our best scientific evidence, that'd be those peer-reviewed studies and other related things, but it also includes two other very important things. The second one is, and in no particular order by the way, clinical experience. So what the clinician thinks about things is very important. Their anecdotal experience with patients it cannot be stated loudly enough. And the same is true with patient preference. If the patient doesn't like something, they're not going to do it. They're not going to be compliant. And think about your own health care. I'm getting at that age where I'm starting to take a few pills now, right? I got a little pill counter up there. And if I don't like something, I'm not going to do it. How is that any different than our patients? So patient preference is critical. So that's evidence-based practice at large. But here's the way I would describe evidence-based practice for P&O. The more I think about this, initially I started thinking about it like a broken three-legged stool. It's not a broken three-legged stool. It's a misshapen three-legged stool is what it is, where one leg is actually a little bit undersized right now. And we need to just kind of grow that leg a little bit, right? And that's that evidence piece. We have more to do there, more work. So that was the doom and gloom. Real quick, the silver lining. We do know some things. I'll fly through this quickly. Here's an example of a systematic review. This is one that our team did. Again, my colleague here, Dr. Hafner, he's done another. There was one done by a group out of New York that looked at bioenergy. So we know some things about microprocessor knees as an example. In the case of the one we did, we put up 3 recommendations. They were graded according to their evidence. They weren't all great, but there was something there. We know something. We recently did another one on elevated vacuum suspension where we put out some grade B, level 2 type statements. And you can see here again, most of them were favorable for the intervention. Not all of them. I mean, that's the reality, right? Everything can't be perfect. And then finally, we were commissioned by the Academy to do one on upper limb. So we looked at what statements could we make between myoelectric and body-powered systems, and actually we made quite a few statements. Some in the area of myoelectrics, some in support of body power, some with activity specific, some with rejection rates, et cetera. There are others in progress. The Academy has commissioned more. Our team is doing a few other systematic reviews. The point is, we know some things. Okay, we have some areas where we can say we have evidence-based practice going on. So, again, I'll close with this for this particular talk. Again, think about your practice as a whole. Think about certain interventions, and think about where are you on this continuum. And you don't have to be afraid of evidence-based practice. It is elusive. It's elusive to all of us to some degree. But again, we do know some things. So, start maybe getting in the habit of checking what evidence exists on a particular intervention and, documenting it accordingly. But again, we're moving into that area where evidence-based practice is the norm. We do know some things. So I hope that your academicians and your clinicians will start working together and pushing the envelope for evidence-based practice. So thank you very much. Appreciate the invitation. Did you, now, I know we had a panel discussion. Did you want to introduce the panelists, or? Yeah. A couple of questions, actually, too. Okay, yeah. So I know we had, again, my colleague from the Pacific Northwest, Dr. Brian Hafner. If you'd come on up, please. And then also joining us on the panel, give me 1 second here, we have Miss Linda Laxo. And we also have my colleague from 2 hours north of me, Mr. Paul Prusakowski. Sure, absolutely. So let's see what we got here. These are questions that come in on the app, right? I mean, this is a new day, right? This is awesome. So, what level of funding is required for quality research? So why don't we just tackle them one at a time? What level of funding is required for quality research? And you know what? So I don't have to be the sage on the stage and steal the mic. I'm going to just bounce it right over to the table. And if they want to bounce one back, then Brian, do you want to tackle that one?
So the first question, is that the way you're asking there? What level of funding is required for quality research?
For quality research, yeah.
That's a great question. I don't think there's a perfect answer. This is ring. Is that better? I'm not sure there is a great answer, Jason. I think, as you know, good studies can be done inexpensively, and good studies can take a lot of money. So can bad studies, unfortunately. But I think it is challenging because good research, good researchers, many of us are funded in positions where our salary is partially or entirely dependent in many cases on the research that we bring in. So it does certainly add up, and studies can be tens of thousands, hundreds of thousands, millions of dollars, and still need plenty more. I can share an example. I had a recent NIH grant to develop the prosthetic limb user survey of mobility that we are going to be talking about later on this week. And that was a study that I guess collectively, if you consider all the costs that were associated with it, was $2.5 to $3 million in US to do that research, all to create what effectively is a one-page survey that many of you will probably, hopefully be using in the future. But there's a lot of research and a lot of studies that had to go into developing it, create the support that we need, and things like that. And I think comparative effectiveness studies work very much the same way, where we do need resources. If you think about a study with microprocessor knees, for example, just acquiring the product alone can be $10,000 or $20,000, $30,000 per device. If you're going to do an RCT with 20, 30, 100 people, that the cost of a study like that can grow absolutely exponentially.
Yeah,
what are your thoughts?
Yeah, let me bounce one over to Paul kind of on this, if I can take a little liberty with a question. Is that okay? So Paul Prusakowski here is, so I'm in Tampa, Florida. He's 2 hours north of me in Gainesville, Florida, if you know the University of Florida. He's in that area. He's a private practice owner, and he also owns and operates a company that assists with the documentation aspect of professional practice. And you can say more about that, Paul, but my question for you related to this about level of funding for quality research was that Paul helped the AOPA Trade Association look at some pilot feasibility work with launching a registry. And they took a small grant to do that. And so, Paul, if you can, to this question about level of funding for quality research, just share a little bit about your experience with the level of funding, what you can share, and kind of how far you were able to move the needle, and kind of where the national conversation has gone since with regard to a patient registry.
Yeah, as far as the registry goes, money's not going to solve the problem. We're going to solve the problem. Ultimately, if we don't collect the information that's important and see that it's important for us as clinicians on a day-to-day basis, association-driven initiatives or government-driven initiatives, there's not enough money out there to get us to change our practices. So the creation of a registry is going to cost millions of dollars and hundreds, thousands of hours of time. But ultimately, it really boils down to what we do every single day in our practices and how we're approaching the patient care process, recognizing that if we don't measure more than just the limb volume and more than just the residual limb length and the size of this calf circumference to make a product, and we're not capturing data that has to do with quality of life, functional outcomes, patient satisfaction, risk reduction, return to work status, and fall reduction, hospital readmission data. Did our patients fall? Is there a higher risk? If we're not looking at that, and we're just looking at the component, really a $10 million grant won't solve this problem. So add a little bit more perspective, but it's in context. The AOPA initiative has been going on for years, and pilot data that we collected from practices, it's Swiss cheese at best, a lot of holes. So we have to take a different approach. And I think Sylvia phrased it really nice in the beginning, that it's the context. It's basically the narrative that we're creating around what we do that's going to define what we do, much more than just the practice of O&P. So I hope
Yeah, that's perfect. And Linda, we have not yet had to meet, so pleasure to meet yet, so pleasure to meet you. Do you want to contribute to this question? The question is, what level of funding is required for quality research? What thoughts do you have?
I'm in a small private practice, and I think as far as making any determination on level of funding, I really don't have enough experience to comment well on that. I know that we work day to day trying to look after our patients as best as we can, making sure we record what we can in a way that we can retrieve it, but contributing to the bigger picture of funding in a big way as a collective. I don't deal with those numbers.
Let's come back to that on the second question. I want to piggyback on Paul's comment about a database and the Swiss cheese that kind of represents the state of affairs with regard to a U.S. Any U.S. initiative at a database. But in the VA, we manage, like I mentioned earlier, plus or minus about 85,000 veterans with limb loss. That's not the limb trauma cases; those are literally just amputation cases. And so millions of dollars, I don't have the figure, but millions of dollars have gone within the system to create a database. And it's not done, and I'll show you the timeline in the next talk that I'm a part of, for the years that it's take to develop that, keep it encrypted and secure, and figure out what vital data elements are preliminarily necessary. And we're not even talking about outcome measures yet. We're talking about, social information, name, identifiers, just so we can track the people and get a count of them. And we're only at that level. We're starting to work toward anthropometric data, and then the vision is outcome data. But this is years down the road, and this is millions of dollars. And I'm an Army reservist myself. I have the utmost respect for our veterans. But at the end of the day, this is millions of dollars to track 85,000 very deserving people. But we need to be able to have the same kind of information for the estimated 1.6, 1.8 million out there in our country that have these impairments and these problems. So when we talk about orders of magnitude, millions for 85,000, what are we talking about for the 1.6 million? I mean, it's going to be enormous, right? And then we got to get all these different health systems to communicate, coordinate, stay secure, et cetera. So let's pause on there. I think Dr. Hafner's answer was probably in a soundbite about the best one, I would say, about this question. How much funding does it take for quality research? It can be anything from unfunded to a ridiculous amount of money, and you could still end up with a less than top quality study, and anything in between. So that's a tough one to answer, but a great question, so thank you for that. Now, getting back to Linda's point about, let me think about, you said, I'm just a private practitioner. And I would say never the caveat in there, never just, right? I mean, you're where the rubber hits the road. You're the most important person in the room, as far as I'm concerned.
I think I represent a lot of the people in the room as well.
And that's my point.
Yep.
You're where the rubber meets the road, and if we're not singing from the same sheet of music, the evidence isn't going to drive forward, the patients aren't going to get the quality care, and why do I even have a job, basically. Right. So here's the next question. Let's tackle this one. Are we as clinical specialists, CPs and COs, best suited to be directing research? Paired with that, should research be organized at the provincial, federal, association level? I'll leave that for one of our Canadian colleagues in the room. Maybe Sylvia, you could jump in and help us with that one. I can't speak to that. But let's tackle this one first. And Linda, why don't you lead off on this? Are we CP, CO clinicians best suited to be directing research? So what initiatives do you do that you're collecting data that you look at internally for quality control, and are you participating in any research initiatives?
I'm not participating in any direct research at this time. I think that as somebody who directs research, I think we would be more of a collaborator, because everybody who contributes to it will bring a piece of the puzzle. So we have the people that are actually seeing patients, working with the patients. We have the questions that need to be asked, and we need to access people who can do the quality research and teach us or guide us on how to collect the data in a way that's consistent and valuable, reliable, and put it together for us. So I think it's more of a collaboration, not one person doing it on their own. And as far as the second question going forward, organizing at provincial, federal level, I think that as we gather the data, if we have more numbers, our results are going to be more significant. We're going to have more reliability when we have greater numbers. So as a small private practice with 5 certified orthotists, we may get a fairly good data collection, but we may only have 20 or 30 patients that fit into that same category that have the same comorbidities that we can make a definitive statement about. But if we engage other practitioners within our province or within Canada or greater, I think our numbers will be better.
That is probably that probably transcends borders. You know, that answer. I mean, if you can get, like I said, the research team from our Washington area. I'm down in Florida. You know, thinking about the map, we're on opposite ends there, and they're canvassing the eastern coast because of that issue, increasing the power to try to get more numbers, et cetera. So let me just ask. Who are the clinicians out there? Who are practicing clinicians out there? Let's show of hands. Yeah, so you're definitely, you know, you're representative of those in here. So, practitioners, do me a favor, keep your hands up for 1 second, if I can burden you with that. We're gonna go analog here for a second. Put your hand down if you're not involved in any kind of research, internal or external. Okay, so those with hands up are clinicians in this room that are involved in some sort of research. Now, can I just ask, you can put your hands down now, thank you for indulging me. Those of you that kept your hands up, if you don't mind, can you share just very briefly what type of research you're involved with? Is it sort of quality control stuff where you're collecting data internally in your practice and you're using the analytics from that to change something you're doing within your practice and it stops there? Or are you doing something in collaboration maybe with an academic center or something else? Anyone that raised their hand for that last bit, can someone come to the mic and share with us? Anyone brave enough to, please? Here comes somebody, a couple of somebodies, great, perfect. This is important because, remember, the big mystery was, you know, this evidence-based practice thing that we can't get our arms around, so this is what we want to hear about.
So it's a combination of different things, but mainly in collaboration with university level facilities. So I think so much of it is comes from that situation of having a question and then having a resource where you can ask that question. I don't have the knowledge or skills as far as that one, accessing that grant money, who and where to access those types of things. So at the end of the day, as Linda says, I can accumulate the information, but then they can do something with it. So it's that whole facet, and I think that's where that collaboration becomes really important.
And can I ask, are you involved with any projects like that right now? Or
yes.
Are you? Okay, very good.
Yeah.
Awesome, super. Thank you very much.
I think for our clinic, it's a combination. I'd say about half the research we're involved in is in clinic, looking at the data we're collecting and trying to do something with it and find meaning and a way of impacting our patients with it. And the other half is partnering with universities and other institutions and providing clinical expertise for their research projects, or working in collaboration to say what's the need, how do we best fill it, and then what's the team that we can put together to answer that question.
Super, and you're just one more second, and yours is a little bit of a unique case, as we heard over coffee this morning, right? Because you actually have some release time to do research. Can you comment on that?
Yeah, so my role is 80% clinical, 20% research, although it kind of is in a little bit of flux, but 4 days a week seeing patients, certified prosthetists, and then 1 day a week doing research of a variety of different types.
Yeah, okay, and was that something, I don't mean to get too deep into your personal affairs there, but since you're sharing, right? Is that 20% something that the practice felt was important enough to carve out time for you? Did you suggest that? How did that evolve?
How did that evolve? I think it was kind of a mutual kind of agreement that we came to that, hey, if we're going to do this, it kind of stemmed from having the masters, and so being one of the first people to have the McMaster saying, okay, if we're going to do this, let's actually put it into practice. So let's set apart 1 day a week to say, what does that master's in practice actually look like? And then from there, kind of grew, and Dave had some ideas, and I had some ideas, and it kind of just 1 day a week, don't touch, that's my research day, and we just, see what happens.
Okay, very good, thank you. And then there's one more up there. Yes, ma'am.
Similar to hers, where being consulted as a clinical, someone with clinical experience. So that's where it's been involved. And I started by doing talks at the University of College, like doing what orthotists do in terms of diabetic wound care, to like the nurses at the college were teaching a 1 day class at the biomechanics And from there, one of the educators invited me to be a person involved with a 3D printing project that they were working on. And so being able to answer some of those questions that they would have stumbled over, not knowing, like I have clinical experience to say, you know, they had designed a hand that closed or opened when it flexed up and closed when it flexed down, which isn't intuitive. And I'm like, that's not a great design. And just being able to catch things like that in the initial process and helping guide some students in their research projects, that's kind of what I've been doing.
Yeah, that's
So
awesome.
less, you know, in my clinical practice.
And so far, what we've heard from the last three folks, yourself included, is these are very formal, sort of higher level research involvement. What I still haven't heard is folks using research for internal quality control purposes. I'm sure it goes on out there, but thank you very much for sharing that. And there's one more.
Thanks, Jason. Fortunate in our facility, it's a private practice, but a lot of the people within that practice are also in a teaching role at the George Brown College. So we have a fairly good connection with education and research, and as a private practice, we really want to invest in that. So we try and provide opportunities or actually make it a requirement for residents coming in to have completed their master's or get involved in research. And once they've done that, look for opportunities, partly for what you were saying, like quality assurance, like how can we make our practice better for our patients, but we're also looking at it on a broader perspective. It's not just our patients, it's patient care in general. So any way that we can advocate for that is what we're trying to do. For sure.
That's, yeah, exciting stuff. So a little bit of both, quality control as well as some larger initiatives, even some student level academic research level projects, which, you know, those are always interesting in their own right, because some, you know, get a grade, that's the end of it, and some move on and actually get published or fuel a grant idea or whatever, you know. So
coming back to the first question that was posted, like the level of funding that's required, some of this research is completely unfunded. It's completely just philanthropically done within our practice. But then there's other more formalized grants that take place between, we would be an industry partner with an academic institution, right? And then those would be a lot more formalized for sure. But I think what's really important isn't so much the level of funding, but it's the people that are involved in that research. If you have a good team with a good question, then you're going to have a much better chance of getting good research.
I just want to comment on that. It's the people involved. In our practice, we have people that are 15 to, I think, 35 years in practice, and there's a huge amount of inertia trying to get everyone engaged and interested in moving forward and doing research. So we've been doing baby steps, and we're at the point where I think everybody's starting to understand the importance of it, and we haven't started anything, but we want to look at different ways that we can measure the practice that we're doing. So we're starting to discuss, well, can we use any of these pain surveys to see if we're making a difference for people that come in with foot pain, and quality of life surveys. So it's basically teaching my colleagues in our practice what's available, what we can do, and how this is going to impact our patient care. So we're way behind the curve in our practice. I'm a little bit ahead compared to the people that I work with because of my experiences with going back to school, but I think it reflects a lot of the practices that people are just starting to understand the importance of bringing research into practice and using the research in practice.
Let's have Paul and Brian weigh in. And Paul, so your thoughts about the conversation, but also if you could add sort of if you've engaged academia, and then Brian, when you answer, your thoughts about academia engaging the clinical community. And Paul, if you don't mind, can we hear from Dr. Schneider just very briefly first, and then we'll kick that back over to you.
Yeah, so this is just another comment to what we just discussed from Planet Germany, where I'm from.
Thanks for that.
Because it is the same situation. We need the stronger evidence. The uni hospitals do the studies because they have the academic and organizational background to it, but most patients are treated in the clinics. They have the numbers, but they do not have the study structures. And so this is why we think in Germany, that's only starting, that ideally these studies do not have to answer this very good question, which is now from this one above, are we as clinical specialists best suited to be directing research, where I think the answer there may be that excellent medical schools here in Canada or the colleagues in the US, they lead these studies, and then you're associated as a clinic to it. You're with modern IT technology like this morning on board with bringing in the patients to add up to huge multi-center studies, and then guided by academic institutions in the private clinic, the data for everyone make things strong, and that may be an affordable and doable step for the future. But also in Germany, we're only starting with these thoughts, but the world seems to be up to them.
Yeah, it seems like sort of similar challenges and the right sort of approach to bring those two together. So Paul, back over to you.
Yeah, just to give some context, currently the system that we've developed is in 1,300 clinical locations. That's the United States, Canada, and Australia. And when we're talking about evidence-based practice, we sort of approach when we teach evidence-based practice a little bit differently. Yeah, we're all the scientists, and the evidence that we're looking for isn't in the journal. The evidence we're looking for is in the patient room. The evidence is in the questions we ask consistently. And if we look at ourselves as scientists using the scientific method to decide why and how we're going to apply orthotic and prosthetic technologies to a patient's clinical care, we're going to be collecting more data consistently. And then we create the pool. And this is what we're starting to see, not just evidence-based practice for clinical outcomes for reimbursement, but for effectiveness in making better decisions in the future. So we are aligning with some of the research institutions, private practices who have been collecting data consistently across multiple centers and starting to cross borders, not reimbursement-driven decisions, purely about how we're approaching the care. What outcome measures do we use consistently to determine what we're going to do and if we actually improve the patient over time. And we have the research community starting to work with clinicians that have been doing this consistently. And it's not the cart before the horse. It's not the research design first and go collect it. It's the research question and then going to people who have pools of data. And it's becoming a really interesting evolution of the practice's data to become a tool that the researchers can access. It's not just evidence-based practice from the clinical perspective. It's also, I think Jason hit on it, it's changing your practices. Evidence-based practice management is what we're seeing too. Take the L codes out, take the provincial coding level out, take the state level coding out in Australia and look at the consistency of what we do. If we're doing everything the same way, minus the coding and the billing processes, we're all clinicians. We treat patients the same way. If we're collecting the same type of data, and it's a lot, there's a lot of data, administrative, clinical, patient satisfaction, financial. All those pieces together give us an incredible pool. And we're seeing best approaches of care. And then we could play with the financial piece with the coding and the governmental issues. But this is really amazing stuff, and Dr. Hafner has been helping us with some of the research designs that as we're teaching our users a starting point, what's accumulating is an incredible pool of data. And yes, it's a little Swiss cheesy right now, but it's changing. Those gaps are filling, there's consistency, and the researchers are coming up with some really nice starting points with the analytics to show that we actually are a little bit ahead of the curve. And it's exciting times right now.
So Brian, just let's maybe hear a few comments about the way, from your perspective, academia engages maybe the clinical community, right? Because that was a question about, P&O's ability to direct and lead and be involved in research. So from the academician's perspective.
Absolutely. I think it's an excellent question, and one that we deal with. I teach classes in evidence-based practice at our university, and this is a question that comes up a lot from our students is, we're training to be prosthetists, orthotists, we're training to be clinicians. Why do we have to do all this research? Mumbo jumbo, why do we have to learn about this? And I think we're all realizing that there's a role of research in clinical practice and that they need to be equipped and armed. And I think one of the great things is all the recent graduates now are kind of coming out with that level of education. And I think historically graduates, come out of college, they go to learn everything that the more senior clinicians at the clinics have to provide, right? But I think this is a little bit of an opportunity for some role reversal where those younger graduates can bring some of that knowledge of research of outcome measures and things like that into the clinic. And I hope as the more senior members that you certainly take advantage of that information, that knowledge that's coming in from the recent educational programs. I think from my perspective as a researcher, I think it is important to know that conducting good, high-quality research takes, I've basically spent the last 20, 25 years of my life learning how to do it well, and I know I still have a long way to go. So I think there are skills, there are resources that we have at the academic centers that probably aren't available to many of you. And so I think the idea of partnerships is really what's great about it. I mean, I think one of the most important things that the practitioners provide us is good questions, right? I think it's all too easy sometimes as engineers, as researchers, whatever, to sit up in those ivory towers and come up with what we think are the problems on the ground, but many times we forget to ask. And I think through the partnerships that we've established in some of our research, we're able to get those lines of communication open. And hopefully by doing that, we're actually doing research that matters and research that will affect some of these issues that are being presented with the profession today. And that's been a real value to some of the collaborations that we've done. And there certainly is strength in numbers. Some of our studies now involve dozens, if not more, clinics across the United States, Canada, and other places, where we're drawing in from the many clinics, because no one person can take all that time to collect that data. But if each one of you takes just a little bit of time and we pool all that together through the resources like what Paul has created, I think we then approach the big data that Sylvia was talking about. And there is strength in numbers. That's data that is really hard for these reimbursement agencies to argue against, because it's just so large. And in absence of gigantic randomized clinical, randomized controlled trials, these are the next best steps that we have, and I think we need to kind of build that infrastructure, build the base of the pyramid, so that hopefully we can work towards the top.
Yeah, very good. So we have, by my estimate here, about 15 minutes, and we have 2 questions, so I think we can do it, right? So buckle up, all right? Let's start with the bottom one here. Are the funding agencies on board with quality research, and then do they see it as valid, and then or is the cost of high-level technology the deciding factor? Let me tackle. Let me just comment a little bit, and I'm going to punt it right over to our panelists here. Are the funding agencies on board with quality research? For the most part, you're not going to get funded if you're not putting a proposal in that suggests that you're going to do high-quality research, and then you show a track record of doing and disseminating high-quality research. So I think fair to say it's probably safe to say that yes, funding agencies are on board with quality research, and hopefully nothing else. I hope they're not funding garbage. Do they see it as valid? The funding agencies will. I think the challenge is getting that information into the reimbursers' hands in our model. Okay, and again, I'm not speaking on the Canadian model. On the U.S. model, getting that information to the reimbursers' hands and getting them to recognize it, and then pay accordingly. For the services. And then the last question is certainly related, or is the high cost of technology a deciding factor? And that's one that is tricky to wrestle with, right? Because European models of the quality type analysis they've kind of came and ramped up, and now economic modeling is something that is always cited as lacking. But then if you produce that, is that really being recognized? And we're not at a place in our evolution that we can say, yes, this is the way to do it. We don't have a clear model for that yet. We just know we're lacking that, and the payers are quick to cite that we do lack it. So let's get some opinions, maybe just right down the line. So do you want to weigh in, Dr. Haffner?
Sure. I actually read the question a little differently than you did. When I stopped funding agencies, and perhaps the individual that noted the comment can clarify, do you mean the reimbursement agencies, or was it the actual, like the grant funding agencies? So I read it as reimbursement agencies, Is that the way that question was intended? Okay, all right. Then I would say, I think their job is, I always try to put myself in somebody else's shoes and try to look at it from their perspective. And I think many times reimbursement agencies, they want to say no and say no and say no until you give them enough evidence that they kind of have to say yes, right? That's kind of their job. And so I think in this particular case, yes. I mean, quality research is the tool that we have to combat the challenge of no, right? And in order to get them to say maybe, or to get them to say yes, that they agree to reimburse, we need that high quality research. And as I've sat on a couple of these health technology assessment panels, and I was a co-author on one of those that Jason flashed up there. And it really comes down to the number of studies, the kinds of studies, the the number of subjects that are in those studies and things like that. So high quality research is definitely important to those decisions that get made, and that's what they're basing their information on, because they don't understand. They've got so many technologies, I think, that are kind of under their purview that they don't understand intimately as we all do, you know, the effect that each one of those probably has on the lives of the people that are affected. So, you know, I see it as critical. I mean, the more research we can get, the better. You know, higher quality research that is, the better, and that will begin to combat that kind of the value of the technology, right? The cost of that technology, and move us ever closer to getting the right technology on the right individuals.
Yeah. So my perspective is from Ontario, and only in orthotics, but I find that the funding agency, the Ministry of Health, they don't really ask us about the research or what we use behind our decisions when we're choosing from our funding code. So basically, when we determine what sort of treatment we're going to be providing to the patient, and we go through the funding guide, it has a list of all the different things, straps, pads, whatever. And they have never really asked where the research is behind what we're doing. I think down the road someday, when eventually they may change our funding guideline, they will say, where is the research for this? So I haven't seen that. On the other hand, for things that are not funded, newer technologies, an example would be the walk aid, they don't cover it at all. But when we go to the third-party insurance companies, usually they say no right up front, and then when we write a letter explaining the benefits of it, they do often provide coverage or funding for it. But again, they're not asking for the research, they're asking for our clinical expertise. What clinical function or advantage will this treatment provide to this patient that is not available to the funded items through the Ministry of Health? So I haven't had any conversation about research with any funding agent.
So
That's my unique perspective and from our practice.
So can you clarify for an American that the Ministry of Health, the social model, just has a blanket policy to put the hand up and say no on expensive, high-tech solutions, but you can opt to pay for a commercial reimburser, and that's where you have to write the justification?
So with the funding model that we have a list of different treatments, and they're broken down into components and additions. And I think eventually new things will be added on, but at this point, I think in the last 14 years in orthotics, nothing has been added. So we go through, we pick, and if it's not on that list, they will not provide funding for it.
Yeah. You see, to me, the reason why you need to get in front of this game, right, is because, and if that is upsetting, the use of the word game, but to us, that's the way it feels in America.
Yeah.
To me, it is, you know, it's like we can't put enough evidence and they keep moving the goalposts, so thus the analogy. Anyway, so if you're providing evidence that the benefits are, you know, reducing costs in other places, if you have that evidence, I mean, that would be very, you know, high level stuff, then it doesn't make sense to say no to it, right, at some point. But until we have that evidence, we just simply don't know. So let's kick over to Paul for one last comment on this.
Yeah, I think I saw the main article, and the current alignment, most recent alignment was regarding patient-centered care or client-centered care, and how O&P fits into that. And I think this, the payers, what we're seeing shifting everywhere is value-based payment. If you can't prove the value, you're not going to get paid. So what's the difference between a component and an outcome? That's really the question. And if we look at ourselves within the context of the interdisciplinary care model, where we have shared goals and shared outcomes, that's going to prove our efficacy. The difference between multidisciplinary, where we're just doing our own thing and we're just O&P, or we're intertwined with everybody to have a shared goal. Our evidence is going to be that we had a successful contribution to the whole patient's outcome, and the physicians and the therapists who are working with us validate that in how we influenced the outcomes in their care of that patient as O&P providers. But again, we have to look at ourselves as a different type of care provider, not a part provider, and communicate with those other team players on the shared goals and outcomes, and make sure we're all measuring the same thing. it's not just about the components and the materials we use. It's about the clinical outcomes. And the payers are not going to be paying, the CMS Medicare system in the United States had the goal of hitting 30% by next year, shifting to value-based payment. They already beat that in March. So now they're shifting to, let's get to 50% value-based payment, which means if you can't prove it, you're not getting this traditional fee-for-service. And this is going to trickle down. What happens there starts to happen everywhere. We're seeing it in Australia as well. Prove what you're doing, and they won't trust us. We're the fox guarding the hen house type of thing. We have to be within the context, in my opinion, of the greater medical community that we're working closely with in alignment to achieve the goals through our contribution, and we'll be seeing more of that.
As we've been moving towards evidence-based practice, what we've noticed is that maybe the payers aren't as interested in what it is we are presenting. Truthfully, they're really not interested at all. However, we still present it. Where I think some of the power of that comes is upon appeal. Those patients now can go and appeal the decision or the rejection to whatever was requested, and they are in possession of science and real data that proves, in fact, that they could benefit from this different treatment than they're currently funded for. And I think that we give them then that ability to at least empower themselves to go, if they want to take things to the next level, we've given them something to take to the next level instead of a billing sheet or a price or an invoice or something.
I think we need to be ready for when those paying agencies start to change and evolve and have our evidence and collect all our data and have the proof before they ask. At least in Ontario and in our certain circumstances, we are starting to do that. We have the evidence. If any of the paying agencies asked us for it, we're ready to give it to them, but they're not asking. But we need, as a collective, need to have good evidence.
Yeah, ours aren't asking either. They're saying we don't have it, and then we try to shove down their throat what we do have, and usually it's not good enough. Yeah. Oh, the lady. Yes, ma'am.
Hi. My name is Annalise Petlock, and I work for the Warrens. I'm a lawyer for them, and I manage their advocacy program. And we take the evidence that actually Mr. Highsmith, you yourself have created, and we put it into a package for funding providers. So I think what's missing sometimes from the conversation is the ability to translate the research that's conducted into the terms for the funding payers, for the government agencies and for the insurance companies. And when you put it into their terms, and this is kind of a legal principle, you say, what's medically necessary? You've defined medically necessary this way. Well, this is medically necessary. Here's the research. Here's the opinion that Linda, you said that's really important. That opinion from the professional is important to the funding agencies we've seen. And we've been pretty successful in the 3 years that we've been doing this kind of advocacy. And then putting it together and saying, you have an obligation to pay for it now. So that's, I think I just wanted to make the point that translating piece is important too, taking that very complicated research. Because everybody in this room, prosthetics, I'm a lawyer, it's way more complicated than law. So taking that very high level blend of the profession and translating it for funding providers who have no expertise in this area. Sometimes when you give them something, I've had a funding provider say to me, this is a different language to me. I don't know what to do with this, I don't know what this means, what does this mean? So that's a barrier to getting that coverage, is that translating piece. So that's it.
Yeah, and thank you for sharing that perspective, because commonly when we talk about translation, we talk about translating something from basically the lab to the clinic, essentially. And you're talking about translating from both those worlds into, I guess, policy and reimbursement, just directly that path.
Yeah.
It's an interesting perspective. Thank you.
And I think it's great because, the Association for OPC and the Warrants together as a national charity, we can really help to move in that direction. I'm really enjoying this, so thank you.
Yeah, this is great. Okay,
And I want to talk to you later.
Yes, absolutely. We're here all week. Let's hear let's hear one more, and then I think we're out of time. I mean, this is clearly folks are interested in this, so maybe we'll have to have maybe a cocktail discussion extension of this or something. Yes, sir.
So part of my question is about the qualitative, quantitative research component of this. One of the biggest issues from an orthotic perspective is that so much of what we do, when we're dealing with a neurological person, Today, we can measure step length, stride length, velocity, all sorts of different types of things. But tomorrow, that person's exhausted, and that AFO is working worse than it was before. So we have a lot of qualitative data, and I think we really need to introduce some sort of some other forms of collecting information that is not so. It's still measurable. I don't really know what I'm trying to say there, but it's that whole situation of we can measure velocity and things like that, but I'm walking way better. I'm more comfortable. What does that actually mean?
Well, it's, let me just comment just very quickly here. We got like 2 minutes, and maybe we can throw this one around very quickly, lightning round, last thoughts. Let me sum it up in my words this way. I mentioned the three-legged stool, and we talked about, basically the best evidence. We talk about the practitioner's expertise, and we talk about the patient's preference in that. And so, from a researcher's perspective, you're talking about kind of mixed methods where we integrate different data collection techniques and this sort of thing. And so that would be an example using a mixed method sort of approach of taking hard laboratory data, velocity, knee moment, whatever, and then mixing that with other types of data like more of the subjective domain, preferences, focus group, this kind of stuff. Some of the more sometimes referred to as soft data, that sort of thing. And so there's absolutely value to that, and it very much is consistent with evidence-based practice models that show the three-legged stool. The key is which data elements do you want to capture, and I think you're alluding more to practice. There's certainly value in the research domain, but also value in practice as well, because like we said, if patients aren't liking something, whatever it is about it that they like or don't like, they're not going to be compliant with it, and then we're wasting time and money anyway. So it's a very important part, and teams of folks are wrestling with this, but it is recognized. Let's put it that way. So let's bounce it down the table here for last thoughts, and we'll close with this, okay?
I'm not sure I have any profound thoughts to add. It was one of my questions as well, is how do we get the other two legs of that stool documented? Because we have to get those things in print in a way that these funding agencies can begin to try to integrate it. One of the things that we do is to try to do some of the softer science work that Jason described, qualitative studies that are either based on surveys or based on focus group, cognitive interviews, things like that, interviews with patients, to try to capture that information, put it into peer-reviewed manuscripts, basically, and then have that evidence be citable down the road. And I think as we try to capture patient values and satisfaction, those are also things we need to try to measure in very systematic ways, but also then to report that information so that we can all draw upon it and learn from it, and ideally the funding agencies will use that information in some of their determinations.
Yeah. I think the main thing that I think about is keep on learning. Whether you're just new to this or advanced, there's always something more to learn about evidence-based practice, and which leg do you need to work on? Do you need to work on your patient care? Do you need to work on your clinical skills and gaining more expertise or communicating with your colleagues? Or is it that research part? If you have two strong legs and you need to work on the third one, that's research. Start learning the terminology, start reading journals, join ISPO or the Academy, get the journals, start reading them and incorporating that into your practice. And as you learn more about what you don't know, and you can build upon that.
I think my closing statement would be the three-legged stool approach that I would present from a clinical perspective, from a practical, tactical, day-to-day. If there's three things we just started focusing on each of our practices and collecting, it would be quality of life data, and there's measures to use for that. Functional outcomes, so you have patient-reported outcomes versus performance-based measures, which are the appropriate for the populations we're serving. And then patient satisfaction. If you just start collecting those three things consistently and make that your initiative, when you have communications with hospital administrators, physicians, and payers, they understand those three things. And it may not have a research paper to justify it just yet, but you can justify your existence and show that you're looking at things very differently, and their eyes open, their ears open, and you put yourself at the table with the rest of the care providers.
All right, we're going to wrap up with that so we don't run into the next session. But again, I thank you for the invitation on behalf of the whole panel. Thank you for having us, and thank you for taking the time to come out and have this conversation on behalf of your patients and professionals.